Hello, my name is Julia Young. I'm a volunteer at the UCSF Patient and Family Cancer Support Center, and I'm one of the organizers of the GynOnc Cancer Friends Circle. It's my pleasure to host this morning's panel on patient advocacy, a topic close to my heart as a 10-year ovarian cancer patient. Our goal is to acknowledge and normalize the challenges of navigating a cancer diagnosis and treatment, and to offer resources and approaches to meeting those challenges. And it's my great pleasure to introduce our three speakers, who will each talk from their different perspectives of patient navigation. We will then open up the conversation to your questions. So please use the Q&A function on Zoom to ask your questions, and we'll cover as many as we can. So first of all, I'd like to introduce Dolores Morehead. Dolores is the Community Engagement Director and Client Support Clinician for the Women's Cancer Resource Center, or WCRC, a nonprofit organization in Berkeley that is dedicated to assisting women with cancer in navigating the complex healthcare system and improving their quality of life through education and support services. In her position with WCRC, Dolores acts as an advocate, counselor, and patient navigator to eliminate barriers so that all women diagnosed with cancer receive quality healthcare. She has worked with diverse populations, including LGBTQIA+, African Americans, Latinos, and Asian Pacific Islanders. In 2008, Dolores received the American Cancer Society's prestigious National Lane Adams Quality of Life Award, in recognition of her decades-long exemplar cancer care and ongoing support to cancer patients. Dolores, really glad to have you here with us.
Thank you, and good morning. So the Women's Cancer Research...
Dolores, I'm just going to introduce the others.
Oh, I'm sorry.
Good. I'm just going to do all three to start with. So I'd also like to introduce Dr. Mark Renik. Mark has been attached to UCSF since the beginning of medical school here in 1975. Followed by a residency in inner city family medicine at SF General, and continuing on as a UCSF family and community medicine clinical faculty member, principally training medical students, including a currently available elective course on advocacy medicine. Mark originated the field of advocacy medicine in 1988, and ever since has a rigorous private advocacy medicine practice down by Ocean Beach here in San Francisco. Welcome, Mark. We'll be starting our presentations by hearing from a patient, Deborah Barnes. I'll let Debbie introduce herself as she shares her own cancer story. I first met Debbie a little over 2 years ago, and I've watched her find her footing to become a fierce self-advocate and also an advocate for other cancer patients, including myself. I think that you will agree that Debbie's journey is an inspiration to us all navigating cancer treatments. So welcome, Debbie. Let's start with you.
Okay, thank you, Julia. Well, this is my story. So I think it is hard to advocate for oneself, period. But I think it's harder for women to advocate for themselves, as we're often raised to think of others first. And I think it is especially hard to advocate for oneself when one has been diagnosed with a potentially life-threatening disease like cancer. And with a life-threatening disease, one wants and needs to know that their physician and care team are doing their very best to help them survive and survive well. I taught human anatomy and human physiology to pre-nursing students for over 30 years. I have a PhD from UC Berkeley, and I routinely read scientific journals. Prior to my diagnosis, I was a strong advocate for my husband when he went through malignant melanoma. Given all of that, one might think that I was well prepared to deal with my own diagnosis, but nothing, and I mean nothing, could be further from the truth. I was literally a deer in the headlights. I was frightened, I was very sick, and I was willing to do anything that my doctor told me to do. I didn't ask any questions. I only somehow knew intuitively to reach out to my friends and family for their support. My symptoms came on suddenly and dramatically. Up to the beginning of June 2018, I was an active, healthy, 66-year-old woman, recently retired and traveling. In just 21 days, I went from feeling a bit off to having 2 paracentesis, a port installed, and being on full-blown chemo with a CA-125 of over 5,000. Less than 35 is normal. I was frightened. I went through all of the appointments and all of the treatments and listened to my oncologist with a level of denial and absence. I felt like I was in a bad dream. When they talked to me, I could comprehend slightly what they're telling me, but not very well. And I am scientifically savvy. I literally went from being a strong, emotionally stable, confident woman to being a weak, quiet, devastated woman with cancer. With stage 4 ovarian cancer, I knew my chances for survival were slim. But by this time, I had met a few other women with cancer, including Julia, who stunned me when she said she had advanced ovarian cancer and was 7 years out. That gave me hope. I began to read more literature and to attend conferences, but I was still not advocating for my own care. When I finished my chemo in January of 2019, I still had 3 lymph nodes in my chest that were enlarged. My doctor wanted to do more chemo. I didn't want more chemo, so I sought a second opinion. The second specialist informed me that they routinely used stereotactic radiation in cases like mine. I took this information back to my doctor, and it took a fair amount of pushback on my part to get them to agree, but I had the radiation. The result was that by the end of March 2019, I was in remission instead of being on chemo. Well, that gave me quite a boost to start advocating for myself, but it also made me start to question why my doctor hadn't offered me this option. At this time, I also reached out to the Ovarian Cancer Research Alliance's Survivors Teaching Students program, and I was directed to our local facilitator, Julia, and thus began my connection with STS and with the Friends Circle of Women, which have been life-saving and incredibly positive experiences. I also learned about the Women's Cancer Resource Center and began to go to support groups and classes there. Reaching out and hearing other women's stories has served to teach me so many things, from side effects to treatment options to complementary medicine, which I have used, and it has encouraged me to continue advocating for my quality of life and my care. In May of 2019, I knew of research showing that PARP inhibitors worked on non-BRCA mutated women like me. I began asking my doctor for a PARP inhibitor. I even brought in all of the articles that I had read. I persisted asking over 8 meetings, getting more insistent each time. But despite my strong advocacy for what I wanted, my doctor kept stalling me, saying things like, well, maybe we could get you those. Oh, you might have to pay out of pocket. When I said I was willing to pay out of pocket, it was my life that was at stake. Nothing changed. So I asked for a second opinion. And this time I went to a doctor who I knew to be knowledgeable about newer treatments. I was absolutely upfront at the first meeting about wanting PARP inhibitor, and my doctor agreed. I immediately switched my care, and 1 month later, I was on PARP inhibitor, and my CA-125 came in below 35. I understood that I had found my fit with a doctor who listened to me, was flexible to a reasonable degree, and who also, along with my care team, was supportive and positive. But it was a struggle to get there, with a 5-month delay of starting treatment, things that I strongly believe a patient should not have to go through. In January 2021, my scan showed new disease, and my doctor discussed beginning new chemo, but once again, I asked for stereotactic radiation. My doctor agreed, it was successful, and I had remained at this point stable. The take-home lessons that I want to emphasize are, number 1, reach out to friends, organizations like the WCRC and OCRA, programs like the Cancer Help Program at Commonweal, and other women with cancer. And do not be shy about sharing your story and listening to their stories. I have learned a huge amount from my cancer friends that has helped me navigate my pathway and to advocate for my care. Number 2, ask questions of your care providers. Persist in advocating for what you want. And remember that everyone, regardless of your health insurance, has a right to a second opinion. Number 3, remember that this is your life and your quality of life, and that you are important. Advocating for the best care possible with a team that you feel listens to you and cares about you is something you deserve. And last, 4, when you're able, give back, whether it's through an advocacy organization or a support group, or just talking to that woman you see in your doctor's waiting room with a deer in the headlights look. This will make you feel better, and it will also continue this community of strong women who help support and encourage advocacy for better care in our shared cancer journey. Thank you.
Thank you, Debbie. I really appreciate you being willing to share your very personal story of how you got your feet back on the ground as you navigated this difficult and unfamiliar terrain. I'm sure people will have questions for you later on, so thank you for that.
Thanks, Julia.
So Dolores, Debbie is obviously a fan of WCRC. Can you tell us more about your organization and your approach to patient advocacy?
Yes, I can. Thank you for having me today, this morning. You know, the Women's Cancer Resource Center was founded by Jackie Winnow and several other women who believed women needed to have a voice about their care when diagnosed with cancer. Second slide. WCRC's mission is to improve equitable access to cancer information, support, and care, especially for those who identify as low income, people of color, undocumented, and are queer or trans. We serve all individuals with any type of cancer. The Women's Cancer Resource Center provides a comprehensive set of practical and psychosocial support services. This includes community-based cancer navigation, peer support, no-cost psychotherapy, information and referral, volunteer compassion program, financial assistance programs, and wellness programs to mitigate the challenges our clients may face. We know that our clients need to be seen and heard, so we began to build trust and rapport with them. We assist women in navigating the complex medical system by walking side by side with them as they learn to advocate for themselves. What this means for our clients is that Veronica and I help our clients develop questions to ask the oncologists, to ask the other staff at the center where they're being served, they're being treated, understanding that they are part of a team, helping them look at getting a second opinion and even taking them to that second opinion appointment. We attend the medical appointments, the infusion appointments, we go to lab appointments with them. We also understand that our clients face other challenges that impact their cancer journey. Most of our clients, as I said, are low income. They're uninsured, they're underinsured. Therefore, they are concerned about such things as rent, utilities, food, transportation, and trusting the systems. For our Spanish-speaking clients, they experience a language barrier and may believe the doctor is right. And so they're afraid to ask the doctor any questions, to get a second opinion, because they believe that he, she, or they may decide not to treat them. In assisting our clients to become a self-advocate, we model what it looks like to ask questions about treatment, about, I don't understand why this medication is being offered. What does it do? What do I do if I become sick? And then we also help them to reach out to understand support is not being weak. You don't have to be by yourself. And it is okay to practice quality of life. Our clients are encouraged to participate in our other services, such as support groups, wellness programs, and activities, so that they develop a safe and supportive community. Veronica and I witness women going from fear to having hope, which encourages them to be a self-advocate, to be able to attend an appointment on their own, and also by giving back to become volunteers and to help others. Next slide. So, in focusing on our mission, you'll see that we have a diverse group of individuals we serve. We prep 26% is African American descent, 12 of Latinx, and 30% European descent, and 9% API. And then those who are multiracial or decide not to tell us. So more than 60% live below the federal poverty level. 70% are covered by governmental insurance or have none at all. And for our clients, COVID has amplified the disparities that they are experiencing. So we're not just helping them with their cancer diagnosis, we are also helping them to move through the system and to understand what they can do and how they can get support around COVID. Next slide. As you can see from the slide, the majority of our funding comes from individual giving, and next from corporate and federal and foundation grants. We don't receive any federal money. We have an annual Swim a Mile, Move a Mile event that is one of our special events. So you can see, since our services are free, WCRC greatly relies on the generosity of our individuals. And for more information, please feel free to go to our website or to contact me. And thank you for this opportunity.
Dolores, thank you so much for sharing that information. I think that it's very important that we financially support organizations like WCRC and the work that you do in supporting many patients through the very practical concerns and issues in terms of navigating a cancer diagnosis. And I just want to sort of acknowledge that, you know, those of us with funds have a much easier time in terms of reaching out for resources. And yet there's an awful lot of cancer is a non-discriminatory disease. And, you know, we really need to be there to support your organization and others. And one of the things we'll want to do is on the website afterwards is to promote your organization and other organizations around the Bay Area who really provide super support. There's many of them. Mabel Huang's going to be joining the social worker breakout groups later on from the Shanti Project. And there are so many others that we really wish to highlight. So thank you for being here. And now to Mark, let's bring you into the conversation. Can you tell us about advocacy medicine and the patient needs that you see and are addressing in your work?
Sure, happy to. Thanks for inviting me. You know, a lot of my physician friends are puzzled by what it is that I do. And what I explain to them is that it's probably what they do for a personal family member or a very close friend or an extra special patient. Let's say someone just diagnosed with or dealing with a tough cancer. It's all the extra things. It's checking the key records. It's making sure they've got good people working with them. It's communicating with the surgeon or pathologist or radiologist. And it's often then searching the medical literature with that person's case in mind and actually reading full text articles, not just a few abstracts. And it might involve calling or emailing authors of on-point papers or those putting on clinical trials, maybe even scouring the country or the world for pre-publication information from recent meetings, what have you. And most importantly, medical advocacy is spending time on an ongoing basis, debriefing with the patient and the family after key appointments or procedures, fielding the multitude of questions and worries that inevitably occur, all the while providing counsel and helping to plot a course for the future. That's when fellow physicians realize what medical advocacy is. I started this work in 1988, and it was a way of trying to help those trapped in medical situations where their doctors or an institution couldn't find a diagnosis or a treatment that just hadn't worked, or where everything had gone wrong. or where they had completely given up on the patient, or worse, that the doctors or institution were utterly unwilling or actively obstructionistic to what the patient hoped to have done. For whatever reason, I've always been pretty good at resolving such dilemmas, and early on found that the answer was not to align myself with the medical profession per se, but rather with the patient. Medical advocacy then is to be wholly patient-centered and to go one step further even, and to be patient-directed. The patient and or, if so designated, their family is my boss. I'm a physician in their corner, serving really as their personal consultant and researcher, advocating to help them gain the information and access and authority they need to be in charge of their own case. I'll consider taking on any patient, any age, any problem. All told, about half my patients have cancer-related problems, often high risk or unusual tumors, recurrent or metastatic disease, and often when expected to work, treatments just haven't been working. 70% of my patients are from outside the Bay Area, from all parts of the country and world, which has really helped me to see the profound geographical differences in the practice of medicine, and also to have a sense of what's going on where. And it's led to a unique network I have of colleagues and healers. About 30% of my patients or their spouses are MDs, PhDs, or lawyers. In other words, people who recognize when standard of care isn't enough. I've always had more patients than I can accept, and so I've tried to stay underground, and for instance, have never put up a website. Just giving this talk, in fact, is a stretch for me. Patients find their way to me by word of mouth, mainly from people I've worked with, and so they've usually heard that I like patients who aren't passive and are ready to work. I don't assume their care, nor do I treat them, other than with information and ideas and hope. I charge as a lawyer would, just for my time, all out of pocket, but with a sliding scale, plus there's a slush fund from grateful past patients to help out. I've always done this work by phone, with 2+ hour new patient appointments and 1+ hour follow-up appointments. Most cases go on over several months, some for years. I don't give up. There are always new things to try. I've had the privilege of working with many exceptional patients, in other words, those who become long-term survivors, including several high-grade ovarian cancers, who despite all odds, and often with use of innovative approaches like immunotherapies, are alive and free of disease 10, 20+ years out. I only take on one new patient a week. Any more than that, and I found my caseload just gets too large, and I become like most physicians, with just too many balls in the air and not enough time. Time really is what's unique about my practice. Complex medical problems require a lot of time, and very few physicians or clinics are set up to provide that time. In fact, I would say that has become the #1 reason why patients find they need my help. Their doctors keep schedules that don't allow them to spend nearly enough time. Even the most straightforward seeming case of a localized breast cancer or newly diagnosed ovarian cancer generates an ever-growing array of questions and issues that need to be worked through. In fact, if I were to make up a list of additional major reasons why patients with GYN or other cancers come to me, it's this. #1, a feeling that their doctors are missing something. But then they're struggling with how to go about getting outside opinions without alienating their doctor. #2, they're struggling with treatment toxicities. #3, they want a plan to prevent recurrence. #4, they desperately want an integrative plan addressing nutrition, exercise, psychospiritual, sleep, sexual functioning, use of unconventional therapies. And #5, they're suffering from imposed hopelessness and a feeling of having been given up on. And COVID restrictions haven't helped any of the above. I've had several physicians who came to study with me, and after a year or two started their own medical advocacy practices. And with them from 2016 to 2018, we put on a community-based medical advocacy fellowship training program for 10 experienced physicians, practitioners from various fields of medicine. And when they completed our very hands-on fellowship, they either became full-time advocates or folded advocacy into their own practices. We've continued a monthly salon in which we present cases and problem solve and mentor each other. It's been a godsend to have other advocates I can refer patients to who need help sooner than I can start with them. Last thing to leave you with is that most advocacy is self-advocacy. So when you get your feet back on the ground after having been diagnosed, don't hold back. Stick up for yourself. And if you're too ill or beaten down, ask someone in your family or a close friend to be your advocate or help you find an advocate. Thanks again for inviting me.
Thank you, Mark. You really have been sort of leading in this important field of, of medicine and in defining what it is. And I certainly know for myself, even after, or perhaps especially after 10 years of navigating a cancer diagnosis, treatment decisions only get harder, and the path forward is less clear. And so the kind of support that you're describing and also that Dolores has described is so very important in helping us move through that. So we're going to open it up for questions. If the three of you like to go off mic, on mic, we can be responsive to that. So let's see what we've got so far. So one of the questions that comes in is, what's the role, if any, for including a team approach that includes peer support from people with lived experience, given that this model has been used successfully in other kinds of patient advocacy efforts? So would any of you like to sort of speak to how peer support has been helpful, both in terms of supporting patients as well as perhaps defining the kind of care and support that's needed? And the kinds of resources that patients need?
Well, I can say in 2007, I piloted a community advocate program, which was having individuals highly trained from our sister program who had experienced various types of cancer. And they became the individuals that I would match with others, and they would then go to medical appointments with individuals. And I found this to be helpful. I am not a cancer survivor. I have over 32 years of experience in this field. And what it did was it allowed, particularly I found also for the Latinx population, for them to be able to hear from someone who looked like them, who spoke their language, and who had gone to and been able to experience what Mark said. They had stopped being quiet. They had actually taken charge. And they were able to see, as Deborah said when she saw you, Julia, that this gave her hope. And nothing negative had happened. They had actually become strengthened. And they were also then able to say something to their family. Because one of the things I found for individuals of color and other folks who aren't, is that people don't want to tell their family. Sometimes they hide it. I had a woman who had a wig made that looked exactly like her hair. So that when she started chemo, she put that wig on and her family never knew that she was going through that journey. And she did it alone, except for the support of us.
And I can say organizations where you have support groups, like the WCRC, but also Friends Circle. WCRC because it's women, I like that, but it's also different cancers. Friends Circle is ovarian cancer, and I've learned a huge amount about particularly side effects and also about treatment options, and it's helped me greatly. It's helped me prepare for side effects before I have them, which is a blessing, an absolute blessing. And it's supportive. It's just absolutely supportive and uplifting. Even when you're feeling bad, I come away from a meeting with the Friend Circle feeling better.
I'll just add that I very often have peer or patient friends of the patient or the family on calls that we do. Our calls have always been group calls, and we use a conference calling feature. And when I began this practice, it was always by phone. And it's so interesting how people just were in disbelief of that. And then the pandemic hit. And now everybody sees how powerful it can be and how you can convene everybody equally on a call together from all over the country. It's easily done.
So one of the, thank you both all for that. One of the things that strikes me is that it's hard to know at what point we need to be taking care of our own healthcare, and sort of how those transitions work. You know, and initially we're so shocked by a diagnosis and we're so dependent upon the gynecological oncologist, in our case, to be that expert and to tell us what to do. And then at some point we need to start to transition to, as I think all of you said, taking care of, you know, really being more of a self-advocate and taking care of the resource, or making the most of resources that are available. And I just like, if any of you could talk to how we should expect to manage that transition, and how you've helped other people through that transition, or some advice that we might give to those of us who are sort of in that difficult stage where we need to start taking on more of a role ourselves.
Well, for me, it occurred when I didn't want to have chemo right after finishing chemo. That's when I started figuring I needed to advocate for myself. But I know every woman is different in terms of how much she can or is willing to advocate. And I was scared that my doctor would take it personally and not, you know, possibly not treat me as well as I'd like to be treated. But I also knew, I think for me, a big push was I knew what stage cancer I had, and I needed to take care of it. And I meant it when I said that fourth thing I said, giving back. And that includes telling other women, you can do this, you can advocate, or here are some treatment options. But for me, the stage just came on because there I was, I needed it.
So Dolores, with the kind of patient population that you work with most often, how do you find, what helps people transition from that deer in the headlights that Debbie mentioned in her story, and this sort of starting to become more of a self-advocate and making use of the resources that might be available?
Well, I'd say some folks that we serve don't get there. And others come from receiving the validation that you can recognize when they're in the medical appointment, are in the car when they're talking, that they're not going and saying things like looking to you. Well, are you going to, Miss Dolores, ask the doctor this question? Are you, Veronica, going to ask the doctor this question? When I see that client I'm working with say, I have a question I'm going to ask the doctor today, or I have a question I'm going to ask the nurse, or you know what, Miss Dolores, yesterday I didn't feel well and I called the doctor and said, I need answers. It's that, and it's me validating that I see these steps. Even when they don't mention it, I say things like, oh, today in the appointment, I saw you make eye contact with the doctor and ask him a question. Because that is what they need to hear, is they have the power to do this. Because our goal is not to have them need us to hold their hand forever. It's for them to be able to move on. With one person, she called and said, I don't need you to go with me to the appointment today. And I realized, oh, okay, wow. But how powerful that was to see her going from crying before she got into the appointment, not asking any questions, looking at me like a deer in a headlight, waiting for me to ask that, to them being empowered to say, I can go by myself. And in fact, I've decided I'm not going to continue chemotherapy. And here's why. Those are powerful abilities for our population who has so many other challenges.
Thank you, Dolores. Mark, do you see any particular sort of strategies or tactics that patients you work with use to become more of a self-advocate? What are some of the key things that you see in that transition?
Yeah, good question. I'm always interested in asking about facing challenges earlier in their life and how they rose to them, and looking to see what their style or technique is, what they've done before to activate themselves. And most everyone will have such experiences and can speak to that often more easily than talking about the whole cancer process. And so I try to then draw on, as it were, their tools already present. It's just a matter of sort of finding them back again. And if it takes it, really a lot of this we're getting into now, how do you activate? How do you be an activator, a catalyst? And I do find that this process of assembling your own team, the people you choose to be on it, the complementary, alternative people, the other practitioners that invariably the patient has to themselves go find because their mainstream physicians aren't going to help them do that. When they begin to get a critical mass of other such people, and they realize that they're in charge of the team, that's really when I see them having accomplished that step you're describing.
Okay, thank you. And I imagine that's very similar in Dolores's situation as well. We've got a couple of other questions coming in. Mark, what's the relationship between advocacy medicine and medical legal partnerships?
It's probably a big part. It's just a part that I've not wanted to be involved with. And I'll say to patients from the get-go, look, this is not about medical malpractice. It's not about going after bad doctors. I've actually found that most doctors are really good. Yet things go wrong sometimes. But the word advocacy has always been more associated with the legal profession. That's true. And all of us in the quote advocacy field have suffered from confusion around this. How much of this is sort of legal something, trying to get even, versus literally the purest form of advocacy. The OBGYN department, they had a lovely sort of definition on their website about how they define advocacy. And that's really much more in keeping with where I'm coming from. Occasionally we'll get involved with insurance companies that are just, stonewalling and won't give approvals and the like. And, those tend to be, I think, easier problems to solve.
So we are very short on time, unfortunately, but I'm going to put you each on the spot now. And as we wrap up, there are so many organizations out there that are available to provide support for gynecologic cancer patients. And I just would like to give you an opportunity to put in a good word for an organization that isn't your own, that you would like to make us aware of. And we're encouraging people to enter in the chat organizations that you found supportive, and we'll try to share that information via the Symposium website afterwards. But would somebody like to give an unabashed plug for an organization that you think has been helpful in one way or another in navigating treatment decisions and life?
I would say Charlotte Maxwell Clinic provides integrative medicine for women who identify as low income and would not have access to those types of treatment because they don't have the financial capability to do that. It's an excellent organization.
Thank you.
I mentioned mine already, so gosh, the WCRC, the Friends Circle, OCRA, especially the survivors teaching students. And I also did the cancer help program at Commonweal, which was excellent.
Yeah, and I'll just echo the Commonweal mention, because they've really sort of set the model in motion in so many ways, in so many dimensions, not just with cancer, but in social justice and different ways to think about the environment. And I've always been proud of my association with them. And I remember one of the first meetings ever in 1990, we spent a whole day as a group talking about intentionality. In other words, as a provider, physician, did you think this person was going to survive, and how that affects survival? And it was a profound experience for me. And I've been involved. You can find talks I've given on their website, and there's a whole long talk and a handout on how to really do advocacy for dealing with or helping people with cancer.
So thank you all very much. There's really a lot more to talk about with respect to this. I'm going to just, as we transition to the breakout, or take a quick break before we transition to the next panel, just review some of the breakout groups that are actually going to support this conversation and take it to another level in various different ways. But Debbie, Dolores, Mark, thank you so much for your time and all of the work that you do. We depend on you.
Thank you.
Thank you.